Okay. Jackie, I'll make a note of that and make the change. Are there any other changes or adds?
Except even.
Thank you, Michael. Would you call roll, please, Jackie?
Yes, Claudia.
Yes.
Thank you. Soledad.
Yes.
Thank you, Kevin.
Yes.
Thank you, James.
Yes.
Thank you, and Genevieve.
Abstain.
Thank you. And Cheryl.
Yes.
Supervisor Matt
Yes.
John,
Yes.
Michael,
Yes.
Elizabeth.
Abstain.
Thank you, Madeleine.
Abstain.
Thank you, Liz.
Yes, as amended.
Okay, thank you, and Chair Janice Garner.
Yes, as amended, but I have a concern, Jackie, how many people approved? We may not have had a quorum for the minutes. Actually, we have a majority, so. Okay. All right, the minutes are approved as amended. Thank you very much.
Thank you.
All right, are there any public comments this afternoon? Please be aware that we can have public comments at any time on any agenda item. So if there are any public comments, please just raise your hand. Are there any public comments that you know of, Jackie?
That's fine. Okay, yeah. Would you like to go to the microphone, please? And just a reminder that comments are 3 minutes, okay? Thank you.
Also, Chris Tejeda has joined us.
Okay, I think I'm on. All right, hello. Yeah. Hello, board members. I'm Cece Casey, a family member, and in 2005, I sat on the mental health board. Some of you may feel as I do. But it does bother me that the Mental Health Service Act reform was changed to the Behavioral Health Service Act. Thought disorders such as schizophrenia is a neurobiological disorder, much like other common disorders, like Alzheimer's, autism, Parkinson's, and it encompasses many symptoms far beyond behavior. There is no mystery to the treatment of schizophrenia. For the past 11 years, our loved one has received evidence-based practice treatment from Mississippi and LA County. That model of treatment is effective to maintain stability and a lifelong pursuit towards recovery. Our family is very grateful for the treatment received and how much all of our quality of life has improved. But now we are aging and we'd like to bring him home to Ventura County. Thank you.
Thank you for your comment. Are there any other public comments?
Public comment from Mary Halpner.
Go ahead, Ms. Hefner.
Yes, can you hear me? Am I unmuted? I can't tell. Okay, I wanted to comment regarding the absence of Scott Gilman. Is that going to be an agenda item or should I comment about that now?
It's not on the agenda.
Oh, it is not. Okay. All right. I just, I'm really concerned regarding the departure of Director Gilman. I'm concerned that there's a pattern in this department of getting rid of people who are free thinkers, who try to make change, or who may be critical of the system. I don't feel that systems can grow unless people are allowed to be able to critique what's happening and to be able to try to move the dial. In this case, it's for people with serious mental illness. When I was first appointed in 2015, I was a wide-eyed and naive person hoping to work to be part of the solution for people with serious mental illness, as someone in my family has a serious mental illness. And I was able to get a close look at what families go through and what people who have this disease go through. So that's why I was on the board, and I was eager and excited and to work with the county, at least to work alongside the county and hopefully get some good programs in place. But in 2018, when the BHAB unanimously agreed that Ventura County should support the IMD waiver, which would allow for more treatment and crisis beds, County Supervisor Linda Parks and Director Johnson, Sue Hughes, met with me to say the county, that was not part of the county's agenda. That is not something that the county wanted to do, and it's not something that they wanted to advocate for. So I started to see where the county's priorities lie, and it's not with people with serious mental illness, where their treatment, their prompt and effective treatment, like CC Casey just said. It's a treatable disease, but we need to provide the infrastructure to do that. In 2019, I drafted a 16-page white paper, which documented what is happening in this county system with people with serious mental illness. And in 2020, I helped to relate a real life situation where a family was trying very hard to get services for a young man who suffered with schizophrenia. And I did relate this information and the facts of this young man's struggle and the family that the struggle that the family was having. At that time, I was attacked by Supervisor Parks and Savette Johnson at a general BHAB meeting, saying that what I did by talking about somebody's illness and somebody's journey to try to find help and the gaps in services was an attack on the seriously mentally ill.
Mary, thank you so much for your comment.
Thank you for your comment, Ms. Hubner. Are there any other public comments? I have a few chair comments, and I also wanted to bring to Jackie's attention that Dahlia Rockman has joined us today. Thank you. All right. There were a lot of good questions and discussions last month with the VAL Corps about providing input for the community assessment and whom they contacted. Jackie has sent out documents from the VAL Corps to BHAB members to be distributed to anyone you feel would like to provide input. If you haven't already, please send the links to any stakeholders, peers, members of the public, or anyone else you feel would like or should be a part of this very important community assessment process. The deadline for input is the end of November. So I can supply the date if you need it, that email went out at a later time. I don't have it in front of me right now. If you'd like to if you'd like to distribute those links to people that you know would like to be part of this assessment process. As I mentioned, there's no secretary's report this month, therefore I will mention a few updates. There are 2 openings for BHAB members, one in Supervisor Burrell's office and one in Supervisor Long's office. Those supervisors are aware and are looking to fill their openings. The Suicide Prevention Conference, Pathways to Hope and Healing, was a great success, with keynote speaker Gabe Turan, who gave us a presentation about how his growing up with a family member's suicide affected himself and the entire family. There were informative breakout sessions and dinner was also served. I have a few handouts that I'd just like to pass around. And also, I believe, Hillary, did you say that you have some? Yes. There are some bags from the Suicide Prevention Conference for our members or anyone here in the room. If you'd like to grab one on your way out. Thank you for supplying those. Appreciate that very much. Yes, the Facing Down Fentanyl Town Hall is on September 27th at 6 o'clock at the Ventura County Office of Education, 5189 Verdugo Way in Camarillo. Thousand Oaks took a step toward opening its first homeless shelter when it won a competitive state grant of $5.8 million. The California Interagency Council on Homelessness announced a $38 38 million in funding to 7 cities and counties to support shelters and other programs for persons who are unhoused. So Thousand Oaks 5.8 million share will help fund the development and operation of a homeless services center and a cluster of 30 tiny homes for as many as 44 residents. The Thousand Oaks City Council has chosen a city-owned vacant lot in Newberry Park for the shelter and navigation center, and picked the nonprofit Mini Mansions to build it. The shelter and navigation center should go through its final city approvals in the fall and will open sometime in 2020. The Ventura County Board of Supervisors has agreed to match the city's funding to run the center once it's open for a total operating budget of around $835,000 per year. All right, now we have a time certain presentation from our Chief of Substance Use Services, Raina West. There is also a PowerPoint.
Okay, thank you, Chair Gardner, and thank you, members of the board. It's really happy to be here. Thank you for having me. We're going to get this presentation up here. So my name is Raina West. I'm the Substance Use Services Division Chief here. I've been here most of the year, and so if you have any questions later, you can ask me about that. But I'm just going to go into our substance use services that we have here at BCBH. So we'll start with the first slide is let's see, what do we have? So this is me, Substance Use Services Division Chief, and the next slide, is our substance use services org chart. So I really wanted you all to see this because we have such a fantastic team here. So we're under Dr. Dennering, the director, and then I've got a senior behavioral health manager. Her name is Jessica Davis, and she recently got promoted from being over the treatment services. So she's fantastic, helps me a lot with everything. And then we've got a new manager named Maria Di Batista, and she's over our substance use treatment services, which includes everything treatment, everything that's billable and drug medical. And then we've got Dr. Ani Flores, who is our driving under the influence manager. And then some of you have heard from Dan Hicks, who's our prevention manager, and we'll talk a little bit more about what each of these divisions are doing. But I wanted to make sure that you all knew about my wonderful team because they are so fantastic, and I'm really, really grateful and privileged to work with them. Next slide. So we have a continuum of care here for FBCB. So we really do support all of the substance use services in the county. So it started with prevention, which is our prevention division. We also do early intervention in the schools. We have outpatient services, which include groups and other individual treatments and clinics. When someone's completed a course of treatment, they're offered recovery services, which is not really treatment, but it's more support for somebody who's just come out of having substance use treatment and they need some extra help. We have recovery or residential services, which include withdrawal management, which is the next one, otherwise known as detox. So that's for somebody that needs 24 hours with the highest level of care. It's our residential services. And then here at BCBH, we offer medication for addiction treatment, which is otherwise known as MAD. And that includes different medicines for someone to take if they're struggling with an opioid use disorder or an alcohol use disorder. And then we also have narcotic treatment programs for people who have an opioid use disorder, and that's primarily methadone, but it's also Suboxone and naltrexone and a few other things. Next slide. So this is just kind of an overview of the treatment services. So like I said, we've got our clinics that we operate here at BCBH. There's 6 of them. 2 of them are here in Oxnard, and one of those is a perinatal program for women who are pregnant or parenting. And then just a variety of outpatient programs throughout the county. We contract with 4 different providers. 2 of them provide residential and detox services. One of them is Hellbright 360, which is a women's program here in the county. It also takes children, so it's for families. And then Tarzana Treatment is in Los Angeles, and they are for men and women, and they both do withdrawal management in those facilities. We also have 2 narcotic treatment program contracts, Aegis Treatment Center, and then also West Treatment Center. If you have any questions during this, that's perfectly fine. I can answer those, but then we'll also time at the end. So this is just kind of overview of our client demographics. So you'll see in that upper left graph that are primarily folks between 26 and 64, but we also have some older adults. We've got a handful of people who are under 18, and then we also serve K age. The primary ethnicity is Latinx. And then the diagnosis over there, that's not including the NTP. So all of our narcotic treatment program clients are going to have an opioid use disorder, but this is for the residential treatment and our outpatient treatment. The primary diagnosis right now, and it has been for a while, is alcohol, followed by amphetamines or methamphetamine, and then opiates for people who aren't in a narcotic treatment program. And then some folks have a cannabis diagnosis or other.
So I see 10% of people have no diagnosis. Why are they getting treatment? And what does other mean? Is that multi-substance or polysubstance?
I think what no diagnosis is, so somebody can come into our services and start to get assessed and to get introduced, but then it turns out that they don't have a diagnosis. So they still would show up as getting, so like they've come in for an assessment. And then they haven't actually gotten, the full array of treatment. So that would be a no diagnosis for that one. And then others, all the other things. So there's inhalants, there's different hallucinogens that somebody could have a diagnosis for. Primarily, those are the 2 on the top of my head, but there's benzos would also be one that's not on there. Yeah, so anything other than those is in the other category. So those are just not as common.
Thank you.
Sure.
Good question. Do you track how long they stay with you? In other words, you see the large primary group, 26 to 64. How many actually move on to 65, and how many came up from the transitional age group? Or do they primarily come in that larger group?
That's a good question. I think it's both of those. So of course, if they were 18 and they were doing our youth services, they would transition to an adult service. But really with substance use disorder treatment, it tends to not be very long, right? So the idea is that somebody comes in, gets the services they need, moves into maybe a recovery support system. And so I can't really see it spanning, generations necessarily. They might have some sort of support, like a touch point, but it wouldn't really be that intense or even that outpatient treatment level.
Okay, I'm just curious, is there an average length of treatment?
That's a really good question. I think it depends. So I know that for the residential and withdrawal management is about 7 days. So it's between 3 and 7 days when someone comes in and they're withdrawing from their substance. And then residential is typically between 30 and 90 days, but then it can go up to 6 months, depending on how severe someone's substance use disorder is. And then outpatient varies. I mean, it's generally at least 3 months, but then sometimes I would go 6 months, and then like I said, sometimes people want to stay on just to get that extra support so that they aren't quite ready to be completely done with treatment.
And if they're co-occurring, they get assigned to the clinic, they take a similar treatment track, someone going to the mental health side of them.
Yeah, so that kind of depends. So if they have a serious mental illness or they need specialty mental health services, then they would get both their mental health services and their substance use disorder services within that clinic. If they have a mild to moderate mental health challenge, then they would get their substance use disorder services within that substance use disorder clinic, and then they might also have a therapist or some other services for their mild to moderate. But within our substance use disorder clinics, we have licensed professionals for mental health, so they'll also help with that and help with some of the groups, the co-occurring groups, but they would probably get their primary mental health treatment outside of the substance use disorder clinic.
Thank you.
Sure.
I'm going to ask all of our rehab members if they would please write down their questions and let Chief West go ahead with her presentation, and then we can ask questions after.
Okay, thank you, Karen. Good idea. All right, next slide. So this is just a little bit more information about our residential services. So like I said before, we do have the 2 providers and there's 4 locations. And we have approximately 204 beds for residential treatment. Those are 3 different levels of care. And then we have about 68 beds available for withdrawal management. We've got, this is pretty neat, so we have 6 recovery residence beds in the county for men, and we just added 8 more, so now there's a total of 14. And we really are hoping to get some recovery residence beds for women soon. And I guess I'll just explain what a recovery residence is. It's a place for someone to have transitional housing while they're accessing outpatient treatment. So it's a federal funded program where a person can have a bed while they're in treatment, but if they're not in treatment, then that bed is available. That makes sense. Okay, next slide. So here's some neat things that we're doing within our substance use treatment services. So we've expanded testing in all of our clinics and we're using Millennium Health. That's a lab that we can send our tests to, and then all of the toxicology tests are confirmed. We're also kind of changing our groups a little bit in outpatient treatment. We're adding some more trauma-informed groups, and we trained everyone in helping men recover and also in adolescent sleep safety. And then we're going to be training them in helping women recover and also amazing dads to kind of switch up the groups in our treatment to make them more appealing, more current for people accessing outpatient. And then we're adding Sublocade, which is an injectable Suboxone in our Oxnard SETS clinic, which is pretty neat. We'll be the second person in the county, or the second program in the county to offer Sublocade. Sublocade is a Suboxone that it's a buprenorphine medication that someone would get injected and it would last for 30 days. So they don't have to take the medication every day. So it's a long-acting injectable. And then we're also adding a new 24-bed men's residential detox center in January. So that'll be really helpful to have something for men in access in the county. So I want to talk about our prevention services now. So this is just the org chart for them. Like I said before, it's under Dan Hicks, but then we also have some really great program administrators and program managers underneath Dan to provide all of their prevention services. One of the amazing things that the prevention team does is go out all over the community. So that's a picture of Alma and Erica, who are our community service, 2 of our community service coordinators. But this is a neat slide that just talks about our total number of outreach events. So this was in the last fiscal year. So they've had lots of presentations, meetings, and just an opportunity to reach over 16,000 people in Ventura County just through our self-promotion. So another thing that they do in prevention is, and I'm sure you've heard of this, is the naloxone and overdose rescue kits. So this is just in this last fiscal year, each one of those quarters, or how many kits were distributed. And based on those kits, they were able to track how many overdoses were reversed. And so at the bottom, throughout this year, through our overdose rescue kits and giving the kits to law enforcement, we've had 1,355 documented overdoses just last year. So without that life-saving medicine, those people could have perhaps been dead. You want to wait Those are all unduplicated, but we don't know all of them. So someone could get a kit and not report it. So that's actually lower. Yeah. Here's our really great contractors. So we couldn't do this work without the wonderful contractors and the community contractors. Yeah, people we contract with. And we've got a couple new ones that are at the bottom, these place and tea trees, but these are people that help us do all of the prevention work here. Something I wanted to talk about is our media campaign. I think it's amazing. Coming from a smaller county, I was really impressed with all of the work that the prevention unit does with media. So basically, we contract with Idea Engineering, and they do these fantastic campaigns for us. So here's a few. There's 3 campaigns that have their own websites, but then also on the next slide, it'll talk about you probably have seen these campaigns. So here's 3 of our primary ones: the Pet Most Forever, It's Just Not Worth It, and Men Don't Buy the Lie. And then on the next slide, all of the campaigns that they do in prevention are also in Spanish, of course. And then this is one of my favorite news slides for prevention. So basically, this is all of the media types that we use our prevention messaging. So there's traditional media, which is just regular TV, radio. We also have all of our digital media. And then lots of location-based ads with a billboard, a mobile billboard that drives around, lots of digital billboards, lots of just ads that are throughout the mall and at the DMV and all over. And so that chart over there really talks about the impressions. And so an impression is how many opportunities it's had for people to see that campaign. So this kind of shows just last year how much prevention has been in Ventura County. This is a neat slide if you get this electronically, because this has all of our websites that you can go to that prevention sponsors, and then just also our VCBH website. We have a Coast dashboard, which will show everywhere, in the community where Narcan is available, where you can get more Narcan and fentanyl test strips. And then of course, we're on social media. So we've done a lot in prevention, but I just, in the fall, some things that stand out for me have been, we recently did a fentanyl test strip rollout. So right now we have fentanyl test strips in we had in the two treatment, narcotic treatment programs, Aegis and Western, but we've expanded it to pretty much anyone in the community who wants to be somebody or an agency who distributes fentanyl test strips. So we had a meeting, we invited everyone in the community who was interested, and decided 10 more agencies up to partner with us to distribute test strips into the community. And then on September 27th, we're going to be doing a town hall. We'll have some different leaders on the panel. We'll have Dr. Jenner will be asking everybody questions. There'll be like dinner, parents, community members, everyone's welcome. This slide says 150 expected, but we had to keep opening it up and opening it up more and more. And I think there's over 220 people expected. So if you want to register, there's probably a wait list right now, but go ahead and get on it, and you can look that up at eventbrite.com. Okay. So DUI, I know that you all have probably heard this because we ended up putting DUI out for an RFP, which is a request for proposals, and we did that on August 11th, and it's closing on September 22nd, which is very soon. And so the idea, unfortunately, DUI has been great here, and we've done a really good job running it, but we are the last county in California, the last county operated DUI program in California to still run a DUI program. And it's because it's just been so expensive to run DUI, and having increased labor costs and have made it really hard. And right now we already have the highest fee structure for DUI of anywhere else in California. So we're hoping that if we transition to a model where that other counties have used, where we can find a contracted provider to come in, do all the same services, lower the cost for participants, and then even expand their operating hours beyond what we have now. So we're hoping they can do it on the weekends and later on in the evenings. And we're going to keep running DUI until we've secured an acceptable contractor. It could take up to 9 months because they do have to get certified with the state and trained and get ready. We don't want to do that until they're absolutely ready. And we intend to integrate all of the current DUI staff into our other behavioral health units. So they can help with different co-occurring programs. They can help fill some of our vacancies, because we do have quite a few vacancies in the substance use services. So I think that's it. Now it's time if you have any other questions, and be happy. I love questions. Yes.
Hold on just one moment, please. I just wanted to mention that CJ Keaveney has joined us today. She's our rehab mentor, and we have a question from Donna.
Hi, my question is that I know you have all these programs for prevention. How about following up after they become sober? Because one of the reasons people overdose is because they go back and they take the same amount of substance they used to do it before, and then that turns to overdose. So what can you guys do for after that?
Well, it's similar. I mean, it's really, the prevention is not just for early intervention, it's for everybody. And that's a really good point. So You're right, the transition period is really where a lot of those overdoses occur, so when somebody's leaving jail, or when they're leaving a hospital, or residential treatment, or even a sober living environment, or even outpatient treatment, and so I do think that part of the prevention, well, I know that part of the prevention's focus is upon those transitions, so getting people to help care coordinate someone from jail, you know, into treatment, or from treatment into a sober place, and also education. So just like you said, you know, making sure that everyone knows that just because they were able to use a certain amount of a substance before they went into treatment absolutely means that when they get out, that same level of substance could be deadly. And so making sure that everyone's got Narcan available, making sure that everyone has that education to know about tolerance, and then also strengthening those transitions of care with care coordinating someone from each level of service to the next appropriate one.
We have time for 3 more questions. Michael, you have a question?
Yes, good afternoon. I'm going to go to try to attention back to this page 5 of your presentation for the demographics.
Yeah.
I'm Michael Rodriguez, I'm the chief deputy public defender one of the units I manage the people delinquency unit. And when I saw 98 under the age of 18, it seemed very low. And so does this include probation youth or youth that are on probation and are being serviced by the DCPH?
It would include, well, what it would include is anyone that's doing a drug medical organized delivery system program. So if they're getting, because I know that sometimes in probation, people will go into other treatment, and it might not be a drug medical program, or they might be getting treatment while they're in the juvenile hall. So those people are not counted in that. So this is just for people accessing outpatient drug medical treatment.
I understood that, but in the juvenile hall, we have about the population numbers around 60 youth at any given time. And so the vast majority of youth who are on juvenile probation are out of custody. The vast majority, because we represent about 90% of all the juveniles who are involved in the juvenile delinquency system, the vast majority who do need and are participating in drug programs are it's Medi-Cal and or through DCPH.
That probably doesn't mean them.
Okay, because this number seems really low for the amount of kids that are in the system.
Okay, I'll double check that, and I'll make sure that that is including those who are on general probation. Yeah, thank you for that.
Chris?
Thank you. Thank you for the presentation. I just wanted to ask about the Tarzana detox facility. So that's the primary facility for adult males then in the county.
Yes.
And then, so when they go there for detox, is there a system to bring them back to the county? Or once they complete the detox, are they left then in Los Angeles County? Or how?
Well, it's not that far away, so they just, yes, so they would, go from the withdrawal management, which is detox, and then from there, they would go into that residential program. And then they would get care coordinated from there back to here, and then ideally, they would be in an outpatient program here and in one of those, recovery residences, so yes, they don't stay there, I mean, unless they want to, we can drag them up here if they wanted to stay, but yeah.
Thank you. Thank you.
Of course.
We have a question from or a comment from our interpreter.
Okay, thank you.
Right, thank you.
Thank you, I do talk, so thank you for reminding me.
We have time for one more question. Kevin, did you have a question?
Sure, great, thanks for doing this. My question on the first submit, I know very little, but if I understood you right, this is under the treatment services, and you talked about the injectable Suboxone. It implied that was a positive thing, and that was currently being at the Oxnard clinic only. So I was curious if that's something that's being looked at, if it's successful and we expand to the other clinics, or if the patients at the other clinics refer to Oxnard one, or how that works.
Absolutely, yeah, so it's just starting in the Oxnard clinic, but ideally we'd get to all of the clinics. Yeah, especially the ones that are offering that. And I mean, we're also helping with a sublocade program in the jail. So people, that's a good way to get people kind of introduced to buprenorphine, and then they can get the sublocade in jail, and then when they get out, that'll give them some time to get set up with another provider to continue that. But yeah, absolutely, I think it would be, it's quite expensive, but it is covered by Medi-Cal. So it's something that we're hoping is, throughout the county soon.
Okay, I have one last question. I just wanted to see if anyone else. Oh, Cheryl, go ahead.
Thank you. I was just curious in terms of that withdrawal management, residential, et cetera. What's the wait time for somebody to get into one of those programs?
I think it depends, so, the local program's a little bit faster because they're right here, but sometimes the, care coordinating someone into the out of county one can take a little bit longer. So it could be anywhere from 3 to 7 days, depending on the person, and depending on what they need when they're there.
And what happens in those 3 to 7 days? You have somebody who says, yes, they're finally willing or ready to go into a detox or whatever. But yet they may have to wait 7 days. What happens in between? Or do you lose a lot of people in that in between
I
time?
think some people do get lost, and that's why we're really prioritizing getting more residential treatment beds that are local. And so I know with Kemper House, who's coming on for those men's beds, they'll be able to take someone that same day if they have availability. So I think that we really would like to move to a model where as soon as someone's ready, they can get in that day. And I'm not saying that that doesn't happen sometimes, so sometimes people will get in that day. I'm just saying realistically, it does take a little bit of time.
Right, okay. So how many beds short are we, do you think? In your opinion?
Well, technically, we're not really short any, it's just that the challenge is that having to go to another county is what's making the problem, right? And so if we feel, if that was easier, then we wouldn't need more beds if Tarzana was like right next door, but so I think it's hard to say how many beds exactly we're short, but we don't have enough local beds for the need, but that's a priority of all of us. And so I'm sure, I'm absolutely sure that we're gonna have a lot more beds over the next couple of years, so. Promise.
Okay, that's all the time we have. Thank you, Chief West. We really appreciate all the information that you've imparted to us, and we'll take a look, or I'm going to certainly take a look at all the campaigns that you have going. And if there are further questions, can our BHAB members or members of the public email someone from your staff yourself?
Yes, absolutely. You can email me.
Okay. Thank you very much. Thank you. Thank you. Appreciate it. I want to give her a round of applause. Appreciate your time coming out today and giving us this information. A lot of this is news to some of us, so appreciate that very much. All right, next we have our director's report, BCBH Acting Director, Dr. Loretta Dennery.
Thank you, Chair Gardner. Hello, as everyone knows, my name is Dr. Loretta Dennery. I am currently serving as your acting director. I'm really excited to, work with most of you. I've worked with some capacity over the years. I've been with the department, for those of you who don't know me, for about 5.5 years in various capacities, most recently as the Assistant Behavioral Health Director, and prior to that, the Substance Use Services Chief. So I'm really looking forward to working with you all in this capacity while I'm serving this role. And I will provide you with some updates this afternoon. So September is Suicide Prevention Month, and as was mentioned a couple of times, we had our annual Suicide Prevention Forum at Oxnard College, and it was a wonderful event. We had staff, community members, elected officials join. It was a wonderful event. And I really want to thank our MHSA staff. Some of them are here today, for the tremendous amount of work that goes into these events every single year. And we began planning very early on. It's such a great need for the community to have resources, as we talk about during the conference, we talk about here, a lot of people are just unsure about how to even tackle the topic of suicide prevention and what that actually means. And so to be able to provide, non-clinical people with actual information on how to talk about these difficult topics, is something we love to do every single year. So it's another great event. We thank our partners at Oxnard College for the wonderful venue, and we look forward to next year's event. This September is also National Opioid and Substance Use Awareness Day. And as Chief West mentioned, we have our event coming up later on this month for our fentanyl town hall. I will be moderating. We have, a panel of local leaders who will be talking about these issues. And again, we're very excited to bring these type of events to our community. Those of you who know me know that I have worked in this area for many, many years, and our county has always been at the forefront, especially around the opioid issue. And so we are very happy to have the support of our elected officials, our healthcare agency leadership, and our county leadership to be able to give, again, the community tangible information on how to move forward, how to talk to their children, how to talk to their family members, and informing and educating about the dangers of opioids. So we're very excited about that. Another announcement I wanted to make is, as some of you are aware, we've had a lot of restructuring in the department over the last couple of years, especially as we transition into our managed care system and more have an insurance company role within our quality services division. And so I'm very excited about a couple of appointments we have. We have our new quality services division chief, Dr. Amir Madavi. He's here today. Today is his first day, so Amir joins us from Los Angeles County, where he worked in the Department of Public Health doing quality work. He's a trained psychologist, also comes from the state correctional system, so he has that background too, which is awesome. Since we have so much justice involved in collaboration with our district attorney, public defenders, and our justice partners. So we're very excited for him to be on board and the leadership there. We also have Miss Karen Lee as our senior manager in that division. She just started in that role a couple of weeks ago. She's been with the department for a few years in quality and has a wealth of knowledge and experience to bring. So we're very excited for the leadership in those areas to be put in place as we move forward, especially in light of all of the mandates under County and MHSA reform, what that looks like for the department.
Wait, no. Because quality division has multiple parts, could you just repeat where they're overseeing which part?
The entire division, so the quality services division.
So over both assurance and
Quality assurance, quality improvement,
so she's in charge and she's second.
Yes.
Thank you.
All right. Next, updates from our Access and Outreach division. We're very excited about our streamlined approach to linking families to clinics and meeting the levels of care that they need. We've been working very closely with our clinic systems and A&O to provide timely warm transfers for the treatment providers. Our Lucrando Bienestar team has been working on several back to school nights and providing workshops for emotional wellness throughout the community. And so we're very excited to continue that work as the school year progresses. Also wanted to note, as part of our suicide prevention awareness month, we have a campaign in public spaces, including at the government center. So if you go right into that area where the board of supervisors room is, we have some resources there, some information there that we're very excited to display. The fall is also audit season for us with the Department of Healthcare Services. So we have quite a few monitoring reviews and audits coming up. Some of those are listed here in the director's report. But the Mental Health Services Act review will start actually next week. So we're looking forward to that. That's a every 3-year review. It's pretty in-depth. This year, they're actually back here. The last review was right in the beginning, mid part of 2020. So it was right during COVID. So we had to do it all virtual and the state wasn't exactly set up for it. So this year we're resuming the way it is for they do site visits. They talk to different levels of staff. I think they may be reaching out to some community members, so looking forward to that. Another announcement I wanted to make was on, the Board of Supervisors approved our behavioral health bridge housing award. So that award is $13.3 million for, various things, including rental assistance, shelter beds, and, we are very excited that we'll also bring 4 full-time housing case managers, which is something we wanted to do for a very long time, so we really are looking forward to implementing this. Again, we will have our Coast Award, or not Coast Award, Coast Fentanyl Town Hall at VCOE. I believe the address, there's a flyer that may have been included with the address, and I saw in the chat, Chris Rich put the address to VCOE. On the audit front, again, just want to put it on your radar, as you may be called as BHAB members to participate. We have our upcoming triennial and DMC-ODS SAGI reviews coming up next month. Again, these are pretty all-encompassing, where they reach out not only to department staff, but community-based organizations, and then folks from our advisory board as needed. And the last thing I want to know is, we've talked about behavioral health integration, what that means. And as the state fleshes out exactly what that is, they have decided to put out opportunities for counties to express interest in wanting to develop and work with them as they develop what that actually looks like. The intent is for all counties to become fully integrated by 2027. And so they gave counties the opportunity to opt in to doing kind of like a joint participation with them. So we submitted our expression of interest and received approval. So we've been invited to participate. So that work group started on the 18th today. And so we will be meeting with the Department of Healthcare Services throughout and working with them to develop the integrated feedback and kind of fine tune the overall approach. As the state moves forward, again, all counties will be mandated to do this by 2027. So we wanted to take advantage of the opportunity to get in front early, have some input with the state, and work through that. So that's it for today.
Thank you, and thank you for slowing down. That was good to know. Before we do, I have questions for Dr. Jennery. I just wanted to mention that there's a correction in the address. And thank you, Mr. Rich, for providing this. The fentanyl, Face Me Down fentanyl event is at 5100 Adolfo Road in Camarillo, and that's on September 27th.
Yes. Sorry, one more announcement we wanted to make. We'll be starting our community planning process for MHSA. We will have 2 sessions for people to come join. Tuesday, October 3rd from 5:30 to 7:30, and that will be right here in our training room. And we'll also have online opportunity on Zoom that same day early in the afternoon. So we will send all of this information out with the minutes, but we encourage you to participate, join us in providing feedback on the plan adjustment. And this covers the 2023 to 2026 update. Thank you.
Great, thank you very much. All right, now questions. Liz, did you have a question?
Yeah. Michael, did you go first? I think, all right, we'll tag team. Dr. Jennery, I have a couple of questions for you. And primarily they're around the stakeholder process for some of the things that you shared with us today. So when you talk about the 13.3 million that was received for behavioral health bridge housing, and you say that we're going to look at 80 units at various home key sites and 5 scattered site units. And who's deciding and who's in on that process? And our stakeholders being included, or is this an internal process? Because it's a lot of money, it's important, we've all been waiting for it, we're very excited about it. But I don't know what exactly the process is and how you start to identify the sites that are going to get funded.
Thank you for that question. So during the application process, the criteria were laid out. And so between collaboration with the department, the county CEO's office, and department leadership, based on the criteria set by the state, is how those units and how those various activities were chosen. And then the state determined the allocations for each of those areas.
Okay, so when applying, you had to already pre-identify where you were gonna spend it.
Yes.
Okay, so that was an internal process. Okay, so will you be sharing with us when, like, what sites you've identified where that money is going? Since it's after the fact now, we don't have input, which is.
Well, so this was, well, I can say that it was brought to this board, at the time the announcement came out. So
It was brought to
to the BHAB,
which fiscal year? This fiscal year?
22,
23?
yes,
So the last,
in March.
okay.
Yeah.
Okay, well, I don't recall that, but, if there's any way that you can share with us where the money's going.
Sure, we can share
the
that.
list and how much and so forth.
We can share the approved application.
Okay, that would be great. The other thing is, I was wondering, you say here in your report that you hired some, CS, community service coordinators and some peer support specialists to staff that housing team. Could you explain what that is referring to?
So we have our housing manager, who's under our adult services, that they will be reporting through the housing manager. So this is a new team that doesn't exist. As part of the grant application we have requested. This is a need the department's had for many years. Oftentimes our clinic case managers who already have a full load also take on these housing responsibilities. And so this will have us have the opportunity to have dedicated housing staff and work with our housing manager, interface with clients and clinical staff for the needs of our clients.
So will they be integrated site specific or with FSPs? Where are they gonna be going with these at?
So all of that will be worked out in time, but this group will be specific to our housing manager and they will liaise with clinics as appropriate.
Okay. Many years ago, when I was on the FS team, I did field work as a recovery coach and support specialist, and we liaisoned with folks that were transitioning to independent housing and all of their facilities throughout the county. So I imagine you're talking about something along those lines to help augment case manager work if the load is so high. Right, okay. Thank you.
All right, Chair Emeritus Rodriguez.
Good afternoon, Dr. Dinner. Thank you for your presentation, for your report. Wanted to completely shift gears. SB 43.
Yes.
Which has significantly expanded the definition of grave disability. As you know, passed, I think it was 75-0 in the Assembly and 40-0 in the State Senate and waits the governor's signature. What steps is the county doing to plan for this in the event that the governor signs?
Thank you. It's a great question. So this is the bill that we have been following basically since inception. For those of you who are not familiar, SB 43 significantly changes the definition of gravely disabled. It adds substance use disorders in addition to chronic alcoholism. It also adds medical conditions as part of your ability to meet criteria. It also outlines basic needs for food, shelter, care, clothing, all of that can be considered. So this is something that we have spoken to our medical director, Dr. Jason Cooper, our substance use medical director, Dr. Joe Blaskovitz. We've all started our conversations about what this would look like. Not just for us at the department, but mostly for our psychiatry counterparts within the hospital system and what that would look like there. Obviously, there will be huge impacts across the county, resources when it comes to the medical professionals who will be called and evaluating these cases. And then obviously all the way to the public guardian's office and what that would mean for LPS conservatorship. So this is something that is going to kind of be looped into a lot of the work that we're starting with CARE Act. It's all related to that. So folks know that this is all part of that platform and with the administration. And so this will be developed as we move through with the CARE Act planning and implementation, considering what this means across the spectrum.
Thank you for all the questions. Oh, we have two more. Okay. Three more.
Four. Cheryl and I have the same question.
Okay, good.
Are we gonna get an update on Scott Goodman?
No, the only update I can share is that he's out on a leave of absence.
Length of absence,
Um, Unknown at this time.
is he still an employee of the department?
Yes.
Okay, Cheryl, go ahead.
Well, I have one question for you first, and I'm gonna comment on what I just said. You said that, in your report, it says the state will consult, come here to review the MHSA and a contact Hillary Carson, but there's no, I don't know who Hillary Carson is, and I don't know how to contact.
Oh, she's.
All right, thank you. That's my first question. Thanks for your report. So, we weren't notified as a board of Scott Gilman's absence, and, you get your agenda and you see that you're there as the acting director, and it's kind of like, well, wow, we're the board. Shouldn't we have had some kind of notice from the department is sort of I guess it's a complaint, but concern that I feel like we were not really adequately notified. I know you can't say anything about it. It's a personal thing. I get all that, but just to know that it's happening, I think we have the right to notice that. And I just want to say that I'm personally disappointed, I guess, because I felt, and we don't know, so there's other things we don't know, and I preface that as a former elected official, I get all that personnel stuff, but it is kind of concerning, because at our last meeting, he reported out on his director's report, and we all clapped at the end of it. That's how much we appreciated what he was doing and some of the changes that he was trying to institute. So I just want that on the record to be known, that I think for some of us, which again, we don't know the backstory, but just in what was going on in the department, there were some good changes that look like coming forward, and I hope those will be continued. It looks like they will be from some report, which I think we appreciate, but I just wanted to voice those concerns. Thanks.
Thanks, Cheryl. All right, Chris, go ahead, and then Elizabeth, and then we need to move on our agenda. Thank you.
Thank you. I just had a couple quick questions. One related to the East County CSU. Is there an update on that project? And particularly if there's still the money set aside for that project in the future?
Yeah, thank you for the question. For sure, we're still working on that. It's again a matter of finding a location, making sure that the cities are amenable, our county is agreeable, and we're all on the same page. But it is still very much a priority, and we hope to move forward soon.
Great. And then just one other follow-up. With Smart Care, I noticed our active consumers data report wasn't in the program. Is that something that we have access to?
No, so this is something that we're still working through as we converted. We converted to a new electronic health record system in July. So with that conversion, it means that we are having to do the reports, get familiar with the new systems. We are still transferring data over from the old system into the new system. And so, we're in the second phase now of, once we went live, kind of the maintenance phase, making sure staff can get the reporting that they need for the state level reporting. That's the mandatory reporting that we have to do, and then our billing also. Those have been the priorities to make sure we stay in compliance. Once we get through those hurdles, then we will resume after we've settled into the new HR with getting the reports.
Thank you. And that just a quick note, that's very helpful for us to see, the discrepancies between the service and how many people get services in East County compared to how many people get services out in Ontario and Oxford. So we look at that really closely, and we're looking forward to that in the future. Thank you.
Okay, Elizabeth, go ahead.
Since others brought it up, I'm also gonna, I hadn't planned to say this, really concerned about Scott's absence. I very much appreciated the knowledge and experience he brought. Because when I actually spoke about really current evidence-based practices, he seemed to be the first person that knew some of these programs. So I was very much looking forward to his expertise in leading the department. And I'm just gonna leave it at that. Nothing personal about any of my comments are never about the people, it's the work. And I have a couple of questions. If I had known we were meeting, or this meeting was October 3rd, I would have changed my flight to get back a day before. I am assuming that's a series of community planning processes, I'm hoping. number one. I'm just gonna rattle off all my questions before Janice shuts me down. That's one question. My second question was about Medicare. It looks like the department's not currently able to bill people that are Medicare only. Is that what this Medicare provider thing is? It's number two. Number three, under the training, I know our county got the mentorship grants for 2 or 3 years. And I'm curious if that data could be included in that. And my final comment about the performance metrics. This is one of the lack of performance and outcome versus process metrics from representatives of the Department of Healthcare Services at various Senate and Assembly hearings is part of the driving force between about quote modernizing the NHSA to the Behavioral Health Services Act. So and I frequently mentioned that it's really important that people that receive services are involved in setting outcome measures. So I know that the QMAC, the Quality Management Advisory Committee, has not met for quite a while. I'd really like to hear what's going on about that. I very much like to ensure that people that receive services are involved in that. And that's also kind of my concern about the report we just had on substance use services. There's no outcomes in it. You know, descriptions is good as we kind of maybe liaise with the department and people that we know in the community. But when there's scarce resources and we need to advocate for services, it would be really helpful to have outcome measures.
Go ahead, Dr. Jenny, and then we need to move on to agenda.
So staff can follow up with you about additional dates for this. The Medicare, we do bill for Medicare. There were some policy changes at the state level that required different enrollments and things like that. So, but we already currently bill Medicare. And then your last comment about the outcomes, absolutely. The state, as you may know, since you sit on a lot of state committees, the state has been very open about their failure to do outcome measures. So that's been a struggle all counties have faced in the last 2 decades with reporting on outcome measures across behavioral health. It's not limited to Ventura County. It's not limited to mental health or substance use. We have mandated reporting that up until this point has failed to do that. That is part of the substantial overhaul under the Behavioral Health Services Act. Read through the bill, there are significant changes to reporting because the state tattled on themselves that they haven't been doing it. So obviously that will trickle down to us because many of you know, I'm a research scientist by training. I'm driven by data and outcomes, and it's always been a struggle using the data that we've been required to collect. So we're very excited about these changes because we can do more than just program performance and actually show outcomes and get them down to the program level.
Thank you, Dr. Jenny.
We're not intending it as a critique solely of the county. I know it's grossly lacking. Yeah.
Next are board comments, and we're going to be doing board comments 3 minutes per speaker and around Robin style, and that means that the first speaker would speak, a second speaker would speak, the third, fourth, as time allows, and then we would circle back to the first speaker. That's what we're going to just continue to go around and around. So, are there any board comments today? Claudia.
So I also wanted to express my concerns about the absence of Director Gilman. In his short tenure here so far, he's had a big impact and has made some important reforms. The one I want to mention is the change to the START system. I remember going on a site visit about 5 years ago and hearing about how dysfunctional that system was and getting people the care that they needed quickly. And nothing happened when we reported back on that being a concern until Scott got here. He also, won the trust of advocates and of us. He came in with fresh eyes. He didn't bristle or get defensive when people made, genuine critiques about the operations of different aspects of the department. And he just had a genuine commitment and
has a genuine commitment and concern for the clients of the department. So I really hope to see him back in this room.
Thanks. Thank you, Claudia. Liz, did you have a question? I mean, a comment, sorry.
Yes, I did. I just wanted to make a general comment regarding Chief West's presentation. Just a couple of things I think is important for staff to keep in mind when you're talking about out of county placements. I don't think it's prudent to say things like Tarzana is not that far away, or it's just quickly over in LA County, because for Ventura County families and Ventura County clients, it's very far away. It's inconvenient. You're not around your support system, your family members can't get to you quickly. So we want to have as many folks cycling back into the county as possible. So the ability to have people come back after detox and have a place to go is very important. But I don't think it's prudent to minimize what most of us feel is a very challenging current situation when it comes to out of county placements. And I don't think that that was an intentional point of view that Chief West was sharing. I think it's just something perhaps that they've become used to saying. And the other thing is, I think when someone is asking about how many beds we need in county for folks that are detoxing and going through substance use disorder treatment, we should have an answer. And primarily it would be based on how many current out of county placements do we have. We need those many beds in county. So I just feel like there needs to be a little more transparency. And I want to thank her for her presentation, but those are some things that concern me. Thank you.
Chris.
Thank you. I just wanted to just comment regarding Director Gilman and what a pleasure it is, to work with him and how open and receptive he is to just support this community. As a consumer, it means a lot to know there's people in the position to help that have the intention just to really look at all the pieces and how they all fit together and how there's gaps within those pieces. But one particular example I'd like to share is when it comes to the topic of 5270, 2-3 years ago, we made an LPS recommendation. There's a series of 8 recommendations, I believe, that the board passed and went to the Board of Supervisors. One of those recommendations was to implement the policy of a 5270, which is the 30-day hold after the 5250 expires. We didn't hear a response on that topic, and when Scott came into this, he pushed for that service, and it's important for the people that need it, and so much so. We have programs in this county who had to work within the means at the time to keep people in placement that needed to be in placement. And that consisted of a lot of times going beyond the scope of their jobs and what they had to do to allow people to leave and then make a complex series of events to get them then into a 5150 hold again, then to transfer that to 5250, because we went 3 years without having the necessary mechanism. So on that single issue and so many other issues, I talked for a long time about that. I just wanted to really share the impact that he's had. And yes, thank you.
Thank you, Chris. Appreciate everyone's comments today. And Soledad, one more. Soledad, go ahead, please.
Okay, yo quiero comentar que por muchos años hemos estado abogando porque haya más información para nuestra comunidad latina en las escuelas y en la comunidad en general. Creo que desde que el señor Scott entró, esta es la persona que nos dio la oportunidad
de ir a nuestra comunidad, con nuestra gente, y hemos notado muchos cambios con nosotros, los padres, porque somos mayoría padres de familia que estamos involucrados en la escuela, y ¿sabe? Anteriormente pedíamos que las personas que estaban al cargo del cargo que tenía el señor Scott nos escuchara fuera de nuestra comunidad, hablara con los padres de lo importante que es tener en nuestras escuelas y en nuestra comunidad toda esa información, y nunca se nos había dado la oportunidad. Gracias a eso también hemos tenido varios talleres de salud mental, que los padres se enteren de lo que significa la salud mental y la importancia que tiene de pedir la ayuda. Seguimos abogando porque sea el acceso más directo. Por esta razón quería expresar que el señor Scott ha sido una bendición para nosotros la comunidad y nos gustaría que regresara.
Thank you, Soledad. Appreciate your comments too. Alright, oh, Michael, oh, you know what, let's go ahead, Michael. Okay.
Understood. As chair, I've had the opportunity to work with 3 different department heads of the behavioral health department. And while I truly had a productive and collaborative relationship with Scott, I'd also want to give my compliments to Dr. Dennering, who I've also had the opportunity to work with as chair. And that many of the things that Scott implemented or put in place under Dr. Dennering's prior leadership. So it's a lot of this is a continuum, and while I do appreciate Scott Gilman's leadership and his work and his insight, as well as his vision, but I would like to also give credit where credit's also due, which is with Dr. Dennering. So.
Thanks, Michael. James, did you have a quick comment? And then we go ahead.
Well, welcome, Dr. Dennering. I'm gonna switch gears a little bit. As you know, I'm a veteran representative, military veteran. Looking through your notes and my brief involvement, we have at the different boards that I go to and present to. I find veterans and first responders to be a very small part of the discussion. So I would just ask that, at least as a bullet point or as a line item, that it is something that veterans and or first responders are invited to the BHAB table or the behavioral health table. I know the county CIT program does have the stakeholder meetings quarterly, so I would ask that at some point we also get one. Thank you.
I appreciate both of your comments. Thank you very much. All right, next we have on the agenda BHAB goals and priorities, and I mentioned last month that the chairs of the committees, if they would go back to their when they have their committee meetings, to go to their participants, including board members and members of the public, and outline 3 goals or priorities that each of the committees feel are important, and to bring that back to us. So I'm mentioning it again, and I do hope that everyone will participate in this so that we can streamline what it is that the BHAB would like to work on. And then the process would be that the committee chairs would bring these goals and priorities back to the full BHAB, and then we would vote on what it is or what they are that we would work on specifically moving forward into our new year and for the rest of this year. So if you would, if the chairs of the committees would please keep that in mind, and please bring that to your participants at each meeting or at the next meeting, please. All right, next, site visit proposals. We had 2 of our BHAB members that had mentioned leading a site visit, one to the IPU and one to the MHRC, the Mental Health Rehabilitation Center. And so I'd like to know if there's any updates on either of those.
Yeah, so I reached out to Division Chief Schiffer and let him know that the process is getting underway, that I've been tasked to do the site visit at the MHRC in Camarillo, Horizon View. And he pointed me in the direction of the contact, the contractor, who's currently on vacation, returning on the 24th. So I'll be reaching out to them and submitting a set of questions to them and setting a date. And I'll be following up with the individuals that have reached out to me that would like to accompany me to the site visit. And then this goal, I was able, through Dr. Dennery's assistance, get a copy of the contract, and I'll be reviewing that so that I have a scope of work and the deliverables with me under my belt before we go over to visit the site. But I imagine my hope would be to get this done sometime in October, and I'll report back. And but I will say that I'm not taking any more requests. So the number of people that I have, I want to keep it very small, just because I know how sensitive stuff. I don't want it to be a huge field trip, so I've already got the folks, and that's where I am. Thank you.
Thank you. Any other information? Next,
As you know, it's executive committee meeting. It was, since I asked to visit, I guess, whatever, Philmont House or whatever it's called with PCMC, the inpatient unit, that I'm waiting for information from the department.
okay, great. Thank you, Elizabeth. Thanks for the update. All right. Data notebook. Oh, it's a misspelling there. The data notebook is, it is sent to us from the state. It is something that the California Behavioral Health Boards and Commissions take a look at, and I would like to defer the information about it to my colleague, Chair Rodriguez, who's done several of these data notebooks. If you would just give a couple, we have a lot of new members here, and I thought it might be informative if you would just give them a brief update about what the data notebook is.
Each year, it's the planning, what's the planning council called, Elizabeth?
California Behavioral Health Planning Council.
Yeah. Where's your member and on the board?
No, I'm not part of the.
No, that's, you're talking about the planning
Right.
commission.
Planning commission.
Correct.
Okay.
And it's that planning commission that can, during the year, will, one, establish the theme of the data notebook. And what the data notebook is a list of data that they attempt to get from each and every county throughout the state. And I don't know what this year's theme is, because the last 2 years I've chaired the data notebook work group. This year, I don't know what the theme is, but usually there's a theme. 1 year it was access to services during the pandemic. The others, it's been I'm drawing a blank. But we've submitted the last 2 data notebook reports, and it's helpful to have it's imperative that we have a productive and working work group to accomplish this. Generally speaking, we would divide up tasks because oftentimes there's data requests from youth and family services, adult services, substance use, and other parts, other sectors of the behavioral health continuum of care. And then so with that, we would divide up, each member of the work group would contact, we would identify subject matter experts within the department, get that data, and then we would convene and then put together our formal response to the data notebook. Once we prepared a draft, we would take it to the full committee, or the full behavioral health advisory board, which would vote yay or nay on it, and then from there we send it up to the state planning council as well as send a copy to the board of supervisors.
Thank you. Actually, this year's theme is stakeholder involvement. And so, I will be asking, to form a work group to, do exactly what, Chair Emeritus Rodriguez mentioned, and that would be to take a look at the data notebook. Jackie, thank you very much, has sent out information about the data notebook. And so for all of us to read, so I will be looking to form a work group and also asking for a lead on the data notebook. So I would ask everyone to please refer back to their emails. Jackie, I don't know, I don't want to put you on the spot, but do you have any idea when that information went out?
Also on the table.
I believe that the information went out might have been last week or 2 weeks ago, but it is on the correspondence files packets. If anybody needs me to send it to them, I can. You can just reach out to me. Thank you.
Okay, thank you. So, anyway, if you'd please take a look at the packets and the information that's on the table and refer back to your emails. This is a very important piece of work that the BHAB does, and we would very much like to have a lead who will take the lead on this data notebook. So please get back to me via email if you'd like to participate. Thank you.
It was Tuesday, September 5th, when
Thank
you said this.
Thank you, Elizabeth. Thank you very much. Okay, BHAB reports. So we have Marlene Torres here, and Marlene has been the chair of the disparities reduction committee. Would you like to give us an update?
I can provide an update. So I'm in the process of rescheduling another meetings. I recognize that we haven't been able to meet, mostly due to conflict challenges on my end. So taking to note some of the requests that you have asked from us, Chair, and we will be scheduling that meeting soon with Jackie.
Okay, thank you very much. All right, and next is the Adult Services Committee report from Chris Tejeda.
Hi, thank you. Yes, we met the first Thursday this month, and we did not reach a quorum. So we'll be revisiting our participant list and then reaching out to try to get it in the right numbers so we're able to hold a meeting. It's getting a little difficult to do the effective business that we're trying to do, right? It's outlined by our committee and the bylaws, and I hope we're able to have full attendance and really work on some of these issues, because we only meet 6 times a year for an hour, hour and a half, and I want that time to be as productive as possible. But for the time being, we've had quite a few just informational opening meetings, so I look forward to improving that. Thank you.
Thanks, Chris. Yes, I did want to mention how important it is that we, with the change of everyone of our board having to meet in person now during our general meetings, our executive meetings, and our committee meetings, how important it is that everyone try and make your committee meetings, because that is where the work is done. So yes, Elizabeth, go ahead.
So Chris, I know 2 meetings ago, we kind of talked about perhaps changing the meeting time, because for me, there's 3 other meetings at that exact same time, and that's why I kind of joined by Zoom late. So I'm just going to encourage you to consider shifting or considering all the conflicts.
Thank you.
Okay, I appreciate that. All right, next, annual report work group, Chair Emeritus Rodriguez.
Yes, thus far I've received, reports from 2 committees and I'm awaiting reports back from 3 at this time. So for those of you who haven't, submitted your reports, if you need, a reminder or a refresher on the topics, then let me know and I'll send that out. So we can get that to me as soon as possible so that we can start preparing the, annual report. And for those who have submitted your reports for the committees, I wanted to thank you again. So please get them to me as soon as possible. Thank you.
Thank you very much. All right, presentation requests. Are there any presentation requests from anyone? If you do,
Yes.
Oh, is there a question? Go ahead, CJ.
Yes, I'd like to make a comment about a request. Some of you may be aware that of late there's been some controversy over social workers accompanying first responders to a crisis incident. And then the social worker stays in the automobile or away from the scene, not able to really converse with the person who's having the crisis. And it ends up being sometimes a fatal situation. But there are some who do get the social worker and along with the first responders. So I think it would be nice to know what happens here in Ventura County whenever there's a crisis.
Dr. Dinnery?
Sure, so we do have, as was mentioned earlier, we have our CIT trained officers who typically are called for those type of responses. I can say that as the crisis response system grows and expands under the state mandates that are coming out now, we will be building out a mobile crisis response. And that's something that, again, we have been working on for years. And now the legislation has caught up to where we've been trying to go. So now we will have the support at the state level through the funding and the Medi-Cal funding to be able to do that. So that is a lot of the work we have been doing the last 2 years. That's the creation of our Access and Outreach Division under Chief Sarah Sanchez. That has been the expansion of our crisis team. So again, these are long, slow processes, but the work has been in place for several years, and now the legislation is catching up. And so there will be obvious parameters on where social workers and clinicians in general are allowed to go. As far as law enforcement needing to secure scenes and making sure things are appropriate. And so we are already working in collaboration with our law enforcement partners on further developing what that looks like in Ventura County. There are lots of different models. LA County has models, LA City has models, other counties up north have models. And so we are actively working with our law enforcement leadership here to develop a model that will work for Ventura County.
James?
Thank you, Dr.
This kind of falls in line with that, but not totally, I could speak completely to that, but what I would like to request is November 10th is Veterans Day. And I do have several people willing to put on a presentation for various cultural competency needs. One person is already in the queue, but I also have backups in case he cannot make that day, so we should like to request that we are before the opportunity.
Jackie, we wanted to go ahead and schedule that for our November meeting. We'll talk about it. Thank you very much. Michael?
Yeah, and it's also important for the public is if they are calling 911 for a behavioral health crisis, that they inform the dispatcher that they're requesting the assistance of a CIT officer. That completely changes the dynamics of the response, but it's important that the public knows that. So to the extent that one is we're behavioral health advisory board, but 2, we're also a means to get information out to the community in different areas of the county, that we put that information out there. Is that again, if someone's in a behavioral health crisis and someone is calling 911, is to request the assistance of the CIT team or CIT trained officer.
Thank you. That's very, very important. Thank you for your comments. CJ, did you have something else you wanted to say?
No, that's
Okay. But Scott Walker has his hand up. Scott, do you want to take the floor?
No, I'm just saying, I was just supporting Michael's comments. It wasn't a hand up, it was a thumbs up. Thank you, Val.
Okay. Well, we always want to hear from you, Scott, so, and you're out there.
Appreciate it likewise.
Thank you. Anyone, go ahead, Chris, Diane.
Good evening, I raised my hand and then I put it down and Chris went up, so I'm gonna just jump in line real quick. I think I want to circle back to what CJ was saying. So at the end of the day, do we want to have the crisis multi-team come and present? We're talking about presentations. I think we should hear from the team, and so we know what's going on right now. We understand the CIT component, first responders on the scene, we understand that. But let's find out, we get an update on what's happening in each department and the mobile crisis team.
So I think that's a great idea. I think we should do an overall for our access and outreach, because again, like I said, some of this is being built as the legislation comes out. So we're in the planning stages for some of it, and we can speak to the entire picture and where we're at and where we plan to go.
And I think what would be great is if you could let us know, like, we're not gonna put you on the calendar right away, because things are still fluid, but when we get to that point where you've got more mandates with a better sense, we don't have to wait until it's the final, end product. Then we can start to have you guys come down and chat with us.
Absolutely.
Yeah, great, so we just want like a placeholder for you on the presentation calendar. Okay, great, thanks.
All right, anyone else? Go ahead, Chris.
Thank you. I would just like to follow up with, quite a while ago, there's, the city of Moore Park and partnered with Caltrans, as well as I think the Moore Park Sheriff's Department and some other groups to, develop a protection along that 23 overpass for suicide prevention. So, and there's some, I believe that project is going, but it's a several-year project until it's developed. So it'd be nice to see a presentation on just what the future plans are. Thank you.
That's been in the works for a long time. I don't know what department's handling that. Do you remember? Oh, go ahead, Supervisor Rivera.
Yeah, I know the PCP's been involved with that as well, so I'm not sure if they would come present. I know they've been working with Caltrans a lot on that project, and it's one part of it.
Thank you. Any other comments? Go ahead, Jackie.
Nancy has her hand raised.
Hi, Nancy, go ahead.
Okay, thank you very much. I'm sorry to be not in person today, but anyway, I had some personal business to take care of. I wanted to just bring it to our attention as something to really seriously look at in terms of who is allowed to write 5150s and when they can be done and how. It seems like it would be it's so limited who can write those 5150s, and they need to be done sometimes, and then they either don't happen in a timely way or they don't happen at all, or people get released. There's all that confusion, and I wonder if we could look at how that works again. I know that the county was trying to work out some things with the different hospitals in the region where they could actually maybe write a hold, and now it appears that they can't. I think there's a lot of confusion in our own minds about who can and who can't, and maybe if we could have that little discussion about how it gets coordinated with the police department and the hospitals and the crisis team, who has what job when, and who gets called first, and all those things that need to be coordinated. I think it would help us to be more aware of how it's going now and how it's going towards the future. I know there's been a lot of work done in making the crisis response better. And so in that context, I'd like to see how we coordinate best with all the first responders who respond to people who are in mental health crisis. Thank you.
Sergeant PC, do you have anything to add to any of these discussions?
I don't know who all the people that are authorized to write 5150s. I know that law enforcement is a big part of that. A reference to CJ's comment, I'm not sure the circumstances of that incident, but I can tell you from a law enforcement perspective that we love to get the crisis team and social workers involved And typically, when there's a call for service with somebody in a mental health crisis, we will bring them in. So, I don't know, usually we don't, unless it's an unsafe scene, right? We try to stabilize the scene. If we can stabilize the scene, then we'd love to get the social workers involved.
Thank you, Sergeant Pizzi. Kevin?
I just, I think what Nancy said, suggesting is a presentation which sort of falls right in alignment with CGA suggesting, and the only thing I think it's totally appropriate, and actually, I would just say, in light of our earlier discussion about the expansion of the definition of gravely disabled, it probably falls right into this evaluation. So I guess I'm just echoing that I think the presentation perhaps early next year in light of that definition changing and how that could affect a 5150-year-old and then who does it, I think is timely.
Thank you, Kevin. Elizabeth, go ahead.
I wanted to share that at the Today Committee, maybe 2 meetings ago, Nancy, who is, I don't know these hierarchical terms, in charge of the youth thing, talks about the TAY mobile crisis team and the really pivotal role that the peer on that team was playing in terms of modeling different ways of engaging. And so we heard a report out on their ability and the work they were doing, but it was also for me personally, as a person with lived experience, expertise, exciting to hear the openness of the people on that team to be hearing from the peer what was working to engage in different ways and then really incorporating that. So we those of us with lived expertise, so we know what works and what's helpful. So I just really hope that kind of openness and the incorporation of peers continues.
Thank you. Dr. Dinnery, not to put you on the spot, but
No, that's fine. No, that's fine. I mean, if it's about that, absolutely. We wrote that grant with the state crisis response 1.5 years ago. So I made sure we put peers in there. And so all of the grants moving forward will have peers because we know how critical they are. So.
Right, and do you think that by January we could have that presentation?
We hope so. Again, you know, everything depends on what gets signed by the governor. He has until October 16th to sign this legislation into place. So hopefully we'll know by the beginning of the year what's what. We can at least give you kind of a skeleton overall picture of where we're going and go from there.
All right, extremely helpful, thank you. Are there any other BHAB comments or comments from anyone online? We have some time actually now. All right, are there, yeah?
Sorry, go ahead, Dahlia. One quick question. I heard from my clients when, you know, their therapist, for example, they called on for 5150 or 911. When they came and they put handcuff on them and they took them. And I want to know this is the reality because it's more, you know, they make them more scared of the situation. They feel embarrassed about, you know, in front of neighbors, other people, because I don't know, they shouldn't be treated like a, you know, criminal or something. So I wasn't sure about that. I wanted to just check.
Okay, go ahead, Sergeant Pusey.
Without exactly knowing the circumstances of some of that, right, I can just tell you that a lot of agencies have in place policies that someone has to be handcuffed before they can be put into the patrol unit, right? So if law enforcement's doing that transport to the hospital or to a treatment facility for a hold, let's say, they have to be placed in handcuffs. And I think I'm hoping, you know, that I'm speaking for law enforcement in general. They try to take in some of those privacy concerns and do it in a manner that's not gonna embarrass them, but that's kind of the reason behind some of that.
Go ahead, Chris, go ahead.
I just have one last follow-up related to this. Is there a mechanism or does it depend on department to department for direct transfer to a hospital, let's say, for the 5150? So I know that some sheriffs or some police departments don't transport to the hospital? Is that something that changes from? I mean,
Good question, go ahead.
So if the crisis team responds and it's somebody that's not, or displaying erratic or violent behavior, they can coordinate the transport with AMR. Sometimes they have vehicles that they can do that transport with as well, but if it's somebody that's displaying that type of behavior, that request will usually be made of the law enforcement on scene.
And is the law enforcement policy to always transport, or does it depend on what their capacity is to be able?
I can't speak for other agencies, but I would think it's just, it depends on the circumstances.
Thank you.
We have a question online, Sylvia Garcia.
Yes, I would also like to ask about the like where the interpretation of the law comes from. I know that different counties have different interpretations, even though it's a state law. I heard that there was a county lawyer that helps interpret that law and then gives that directive down to the agencies. So that would be my request for that. And then also looking at what other counties, how they kind of interpret the law as well. And the reason I'm asking is because as a family member of a loved one that's mentally ill, I've been told by sometimes the police in the past that hitting yourself is just an act of aggression, where in maybe another part a police officer might interpret it as hurting yourself, or running in traffic is not actually follows, it might follow under hurting yourself but not gravely disabled. So and I think Mr. Rodriguez can explain more to that about if you want to be 5150 or under conservatorship, it has to be under gravely disabled. So there's just a lot of things and a lot of questions that I've had, and I think that the police officers spend so much of their time explaining this to the families because they also have to de-escalate. So I've had police officers try to talk me down during a crisis, and they've had to spend maybe a half hour to an hour trying to talk about the situation when I'm trying to argue, well, I see it this way, and then they're saying, well, it's not this way. And so I don't think it's really fair to them trying to explain this to a family member. And if you go to the crisis team website on VCBH, it says nothing on the crisis intervention. It gives out the number, and that's all it gives. So for me, it's always been like this secret entity of who makes up the crisis team or what the rules are, because it seems to change throughout the years. In the past, I've been told that your family member has to be at your location, which makes it hard. And now they said, oh no, you just have to have eyes on them. And then when I said, well, that's changed, and they're like, oh no, that's always been the case. So I'm not saying that there's like this intentional means or trying to lie, but there's definitely a lot of inconsistencies, and it doesn't help when it's not, you can't go to the website and see like, okay, what constitutes calling the crisis team, because there is just not any information, or what exactly under those, how does the county interpret what the 5150 or what gravely disabled is. So to me, it's just not transparency when that information isn't widely out there. And then the police are having to take so much time trying to talk to the family members and trying to explain it to the best of their abilities. So I definitely think that that's a discussion that we need to have. Thank you.
Thank you for your public comment. Appreciate that. We can't respond to a public comment, but James, did you have something you wanted to impart?
Yeah, I just wanted to say that this really highlights the need for maybe a CIT presentation on 50-50-olds and applications, because I think it's important to understand. So I've lived experience as a young man. I had a family member with mental illness that would come around, and I witnessed him be taken on polls several times. Back then, didn't know what it was. I've also been involved in hundreds, if not thousands, of situations in the streets where I was exposed to either as a backup partner, as the primary, someone in crisis, and oftentimes we are the crisis team, and that's who we are. We train a crisis intervention team. I was an instructor for a short period of time. One of the reasons I got involved was because of my lived experience back then. Now, fast forward, I became a SWAT crisis negotiator as well. And when people are in crisis, oftentimes there is a safety issue to be dealt with. And if that situation is unsafe, or if there are mitigating factors for transport, that person is actually handcuffed for their safety. And that's where I think education will come in, because part of the application for the hold, there is a disclaimer or a statement on there where we tell the person after it's been de-escalated, you're not under arrest, but you're being placed in handcuffs for your safety, for transport. And then when we arrive at the hospital or to behavioral health, if they don't have to be medically cleared, then the handcuffs are removed and the situation is hopefully stabilized and the person can be taken out of handcuffs. So that's, again, from hundreds, if not thousands of contacts that I've had and witnessed. But the caveat that I haven't worked the streets for a little over 8 years. So there have been changes to the law. The forms may have changed. So I think this really highlights the need for that type of presentation.
Thank you. I agree. Elizabeth, go ahead.
Liz.
Sorry, Liz.
Okay, no problem. I just want to quickly say, we've had multiple presentations from the CIT folks. We have a great working relationship with them. They work very closely with the community, CBOs, advocates, clients and families. We've participated in their training programs and done role play. We know a lot about what goes on with CIT. They're excellent. We have a strong CIT presence in the county. I think what we need now is to make a distinction about CIT as a separate entity and a resource, and the crisis mobile response team from BCBH. So I think that if we get that presentation beginning of next year, Dr. Dennering can walk us through what currently is happening. We'll see how CIT folds into that response. But unless other people here feel we need another presentation, I don't necessarily think we need to hear from CIT again, but that's just me. I just want to go on the record. Thanks.
Okay, thanks, Liz. Any other comments from BHAB members or anyone online? All right, thank you everyone for this great discussion. Oh, okay, Elizabeth, go ahead.
Are you about to? No, I want to know, like, the general comment?
General comments. Yeah.
Again, this is not about you as a person. I was extremely frustrated that our questions toward especially the center presentation were really truncated and shut down when we know the agenda is for another hour. We've kind of talked about this meeting as being a forum for everyone to get questions answered and get clarified and get as much information as possible so that we can share that with people throughout the various communities in this county. So it feels really harsh, and feel like I didn't get questions answered that I have. So, and especially now that we have all this time that we're just kind of filling with whatever comes up. I just really feel the need to say that, but I really hope that the facilitation encourages thorough discussion of the presentations that we're getting.
Thank you for your comment. Are there any other comments? All right. Next we have the contracts. Oh, contracts. Are there any, oh wait, I'm sorry. Presentation requests, we do that. Recognition awards. If there are any persons that you feel should be recognized by the BHAB, please send your request to myself and to Jackie, and we'll take that under advisement. And the next item would be contracts, and we see that there are none for the month of August. Are there any public comments from anyone other than BHAB members? With that, we will adjourn the meeting, and our next general meeting will be Monday, October 16th, 2023. And prior to just closing, I did want to again thank our presenter and also make the comment that we never know how long questions and answers are going to be. We never know if we're going to be able to end on time, or if we're going to be ending up early, or if we're going to be late. So I don't have a crystal ball, but we do the best we can. So thank you everyone for your comments, and we will see you soon next month.
Thanks, Jen.